Have you ever actually stopped to wonder how fast our eyes grow? And maybe more importantly, how we fix them when they don't grow perfectly? Think of the human eye as this incredibly complex biological camera. From the literal moment we're born, this camera is rapidly assembling itself, it's adjusting its focus, and it's physically elongating to capture the world around us. But what happens when that biological hardware misaligns?
Well, welcome to The Explainer. I am absolutely thrilled to guide you through this material today. We're going to embark on a fascinating clinical masterclass detailing the remarkable journey of human vision. We'll be tracking the eye from its absolute earliest developmental stages in pediatrics all the way through to advanced adult contact lens management. Okay, let's dive right into this. Here is our visual roadmap for today. We've got pediatric visual development, systemic and vision risk factors, testing eye movements, prescribing for children, the contact lens toolkit, and finally, managing lens complications.
Section 1, Pediatric Visual Development, the growing camera. So it's absolutely essential to understand that a healthy eye physically changes shape and elongates during childhood to achieve clear vision. It's wild. This timeline maps out those critical developmental milestones right alongside a child's visual capabilities. And the testing beautifully evolves as the child grows. Like at 6 months, an infant is really just mastering that suck and grasp reflex and offering up a few smiles. By 18 months, we're seeing self-feeding and speaking their first couple of words. Then, right around 3 years old, we can actually start using preferential viewing charts to estimate their visual acuity, and this perfectly aligns with their new ability to draw circles. By age 5, they're matching Leah symbols on flip cards. And finally, by age 7, they've got the cognitive maturity for standard visual acuity tests and a full subjective refraction to perfectly dial in their vision. Now, you might be wondering, how on earth do we measure vision before a child can even read or speak? Well, forced preferential viewing studies brilliantly illustrate exactly how we do this. A clinician basically observes the infant's gaze when they're presented with a pattern versus a completely blank screen. It is a purely behavioral observation, for sure, but it's a highly effective way to confirm that near-adult visual acuity is developing properly, way before the child can verbally tell us what they're actually seeing. So, what happens as this biological camera finishes growing? Well, we have these clinical targets for a fully grown eye, which is known as axial length. A normal adult male eye reaches about 23 to 24 millimeters in length, while a female eye is just slightly shorter at 22.5 to 23.5 millimeters. But take a close look at that final metric. If the eye elongates just a tiny fraction too much, say past 24 millimeters, the patient develops myopia, or nearsightedness. The hardware has quite literally outgrown its optimal focal point. It's fascinating. Section 2. Systemic and vision risk factors. The hurdles. Of course, it's not always a perfect process. Several systemic conditions serve as major risk factors for visual development. For instance, Down syndrome carries a much higher incidence of conditions like keratoconus and cataracts. But the data on cerebral palsy, it is particularly striking. A staggering 75 to 90% of patients with cerebral palsy suffer from visual impairment. This often stems from cortical visual impairment in the occipital lobe, which profoundly affects their movement, their balance, and their posture. Dyslexia is another major hurdle here, as it's strongly linked to poor binocular and oculomotor function, especially those really fast eye movements. But wait, there is a massive beacon of hope in the clinical data regarding dyslexia. Studies show a completely massive 78% improvement in reading ability for dyslexic patients after they receive proper vision therapy or refractive correction. That's huge. It really highlights just how absolutely critical catching and treating these oculomotor deficits can be for a child's academic future. Beyond those systemic issues, we're also on the lookout for specific risk factors that can lead to a lazy eye. One fascinating, albeit totally disorienting, condition is occulopsia. So, unlike standard nystagmus, occulopsia is actually caused by a dysfunction of the vestibulo-ocular reflex. Because the patient lacks the crucial gaze-stabilizing eye movements when their head naturally moves, they suffer from this constant, unsettling illusion that their environment is literally physically moving and shifting around them. Section 3. Testing eye movements. Tracking the deficits. Right, so if a patient has poor oculomotor function, we need really precise tools to track those dynamic deficits. Clinicians evaluate two main types of conjugate eye movements. First, we have saccades. These are the really fast, voluntary movements your eyes make when they're jumping from one word to the next while you're reading.
Then we have pursuits. These are the slow, smooth movements you use to consistently track a moving object. Understanding the mechanical difference between these two actions is absolutely vital for diagnosing exactly where a patient's visual processing is breaking down. Section 4. Prescribing for Children, Clinical Solutions. Okay, let's talk solutions. How do we actually formulate prescriptions for young, developing eyes? The clinical guidelines change depending on the age bracket. We're talking 1 to 4 years old, to 3 years old, and then 5+. But notice the rule for anisometropia. That's a condition where the two eyes have significantly different refractive powers. If that difference is greater than 1 diopter, the strict guideline is to give the full prescription. The source material references clinical studies showing that bilateral amblyopia is highly effectively treated simply by providing this full corrective prescription early on. Let's ground this with a real-world scenario from the data. Imagine a 3-year-old patient. Their right eye is plus 1.00, and their left eye is plus 3.00. Classic anisometropia. According to clinical best practices, we prescribe the full plus prescription for full-time wear, especially for reading. And then, we review the patient in 6 months. The absolute critical takeaway here is that we do not immediately refer them out for aggressive amblyopia treatments, like eye patching, right off the bat. Actually, often just giving the brain the correct optical hardware full-time is more than enough to let the visual system self-correct over those 6 months.
Section 5. The Contact Lens Toolkit, Advanced Corrections.
As our patients grow out of childhood, their visual needs obviously change. Which brings us to advanced adult vision correction. And, choosing between contact lenses and spectacles isn't just about cosmetics. It completely changes the optical physics at play. For myopes, or our nearsighted patients, contact lenses offer less relative magnification compared to glasses, which actually results in better overall visual acuity. Conversely, for hyperopes, or farsighted patients, spectacles offer less relative magnification, which gives them better visual acuity in glasses than in contacts. It really all comes down to where the lens sits relative to the eye and how it manipulates the image size. Now, what's really interesting here is that this busts a very common clinical misconception about rigid gas permeable, or RGP lenses. The physical optical power of an RGP lens is dictated by its refractive index, its central thickness, and its posterior curvature. What does not influence the power? Oxygen transmissibility. I mean, sure, oxygen flow is absolutely crucial for overall corneal health, no doubt about it, but it has literally zero effect on the actual refractive power the lens provides to the patient. Section 6. Managing lens complications, troubleshooting. Of course, placing a piece of plastic directly on the eye isn't without its risks. Sometimes, the physical fit is just wrong. We've all seen it. If a rigid gas-permeable lens keeps popping or ejecting off a patient's cornea, which is super common when a spherical lens is placed on a highly astigmatic eye, precise modifications are needed. First, we increase the total diameter for better superior lid attachment. Next, we increase the back optic zone diameter. And finally, we decrease the inferior edge clearance. These 3 exact adjustments stabilize the lens and keep it securely on the eye. But what happens when a lens damages the eye itself? Well, we can quickly diagnose complications by cleanly separating them by the corneal layer involved. It makes the dense data so much easier to remember. If a patient presents with guttata, you instantly know it's a complication derived from the inner endothelial layer. Conversely, issues like epithelial lycrocysts, dimple veiling, and punctate keratitis, those are strictly derived from the outer epithelial layer. Organizing the pathology by anatomical layer like this really helps to instantly clarify exactly what's going wrong beneath the lens. We've covered the journey from infancy all the way to adulthood, but the eye's evolution, it never truly stops. As we age past 30, our axial length finally stops growing, our cornea naturally flattens out, and the eye's overall refractive power begins to decrease. The biological camera is constantly, endlessly recalibrating itself, and it leaves us with a fascinating question to ponder. Given that the physical structure of our eyes will literally never stop changing, how will your vision adapt to the lifelong journey ahead?